What if one of the most dangerous decisions you could make for your long-term health is also one of the most commonly recommended? We tend to think of surgery as a triumph of modern medicine, precise, life-saving, almost miraculous. And often, it is. But in the world of aging biology, the story becomes more nuanced. Because after the age of 65, the body is no longer operating under the same rules of repair, resilience, and recovery. The same intervention that restores function in a 40-year-old can initiate a cascade of decline in a 75-year-old. So the question becomes not just, can we do the surgery? But more importantly, what will this surgery do to the biology of aging itself? You see, aging is not simply the passage of time, it is a gradual shift in cellular communication. Mitochondria lose efficiency. Stem cell reserves shrink. Inflammation becomes chronic rather than acute. What we once called recovery becomes, in many cases, incomplete repair. And here lies the quiet danger. Certain surgeries, especially those considered routine, can amplify this fragile biological state. They can accelerate cognitive decline, weaken immune resilience, and in some cases, reduce lifespan rather than extend it. Not because surgery is inherently harmful, but because context matters. Biology matters. Timing matters. Hey everyone, and welcome back. If you are passionate about natural health and evidence-based wellness, you found your tribe. For those just joining our health journey, welcome. We are thrilled to have you here as we explore the fascinating intersection of ancient wisdom and modern science. Do not forget to hit that like button if this content resonates with you, and subscribe so you never miss our deep dives into natural health solutions. We would love to know where our amazing community spans. Drop your city or country in the comments below. Now, let us step into a conversation that is rarely had openly. Today, we are exploring 5 surgeries that seniors should pause before agreeing to, not out of fear, but out of awareness. Because when we understand the biology beneath the decision, we reclaim something powerful: agency. This is not about rejecting medicine. It is about aligning medical intervention with the deeper logic of the human body. Because the future of longevity will not be defined by how aggressively we treat disease, but by how intelligently we preserve function. And perhaps the most important question we can ask is this: are we extending life, or are we protecting the quality of the life being extended? Let's begin. Before we examine specific procedures, we need a framework, a biological lens through which we can evaluate risk, recovery, and long-term impact. Because without a framework, decisions become reactive. With one, they become strategic. Today, I want to walk you through 6 core insights, each rooted in emerging longevity science that will reshape how you think about surgery in later life. Each of these is not just a concept, but a tool. 1. The inflammation amplification affects surgery is, by definition, controlled trauma. In younger systems, inflammation rises and resolves like a wave. But in older biology, that wave often lingers, transforming into chronic, systemic inflammation. This is where complications begin. Studies from institutions like the Mayo Clinic have shown that prolonged inflammatory responses post-surgery correlate strongly with delayed healing and cognitive decline. 2. Cognitive fragility and anesthesia sensitivity. The aging brain is exquisitely sensitive to disruption. What we call postoperative cognitive dysfunction is not rare, it's under-discussed. Research published in journals like The Lancet has demonstrated that general anesthesia can accelerate memory decline in vulnerable populations. Think of it as a temporary fog that sometimes doesn't fully lift. 3. The muscle loss cascade. Its sarcopenic collapse, even short periods of immobilization, can trigger rapid muscle loss in seniors, a process known as sarcopenia. 1 week of bed rest can reduce muscle strength by up to 10%. And muscle, as we now understand, is not just for movement, it is a metabolic organ tied directly to longevity. 4. Energy debt and mitochondrial overload. Every surgery demands energy, not just in the operating room, but in the weeks of recovery that follow. Yet aging cells produce less energy due to mitochondrial decline. When demand exceeds supply, the body enters what I call an energy debt state, where healing competes with survival. 5. The immune system trade-off. Post-surgical recovery temporarily suppresses immune function. For younger individuals, this is manageable. For seniors, it can open a window of vulnerability, increasing susceptibility to infections, complications, and even latent disease activation. The immune system, in essence, is forced to choose its battles. 6. Functional versus structural outcomes. This may be the most important distinction of all. Surgery often focuses on fixing a structure, a joint, an organ, a blockage. But longevity is about function. Does the person move better? Think clearer? Live more independently? Or have we corrected an image while diminishing the whole system? Now pause for a moment and consider this. How often are these 6 factors discussed before a surgical decision is made? Not in depth. Not in integration. Not as part of a unified strategy for aging well. And yet, this is precisely where the future of medicine is heading, toward personalization, toward systems thinking, toward biological alignment rather than isolated intervention. If this perspective is already shifting how you think about health decisions, consider subscribing, because what we are building here is not just information, it's a new model of human optimization. In the next section, we'll begin with the first of the 5 surgeries, one that is often presented as routine, almost inevitable, yet carries hidden risks that most people never see coming. And once you see them, you may never look at it the same way again. There is a procedure so common, so normalized, that many people don't even experience it as a decision anymore. They experience it as a milestone. A quiet assumption that this is just what happens when you get older. I'm speaking about knee replacement surgery, a procedure performed hundreds of thousands of times each year, often recommended for chronic joint pain, arthritis, or reduced mobility. At first glance, the logic is straightforward. The joint is worn down, replace the joint, restore movement. But biology is rarely that linear. Because what we are replacing is not just a mechanical hinge, we are intervening in a deeply integrated system of nerves, muscles, immune responses, and energy regulation. And here is where the story becomes more complex. A landmark study published in JAMA found that up to 20% of patients report persistent pain even after technically successful knee replacements. Not surgical failure, biological mismatch. The structure was corrected, but the system did not fully recalibrate. Why? Because pain is not just a structural signal, it is a neurological memory. When a joint has been inflamed for years, the brain rewires itself around that pain. It becomes hypersensitive, almost anticipatory. So even after the joint is replaced, the nervous system may continue to broadcast discomfort. Now layer on top of that the realities of aging biology. After surgery, mobility is reduced, even temporarily. And in that window, muscle begins to disappear rapidly. Research from the Cleveland Clinic shows that older adults can lose significant quadriceps strength within days of immobilization. And this matters because muscle is what stabilizes the joint, not the implant. So we are left with a paradox. We replace the joint to restore movement, but in the process, we weaken the very system required to support that movement. And then there is inflammation. Surgery introduces a controlled trauma, but in seniors, the inflammatory response is often prolonged. Instead of resolving cleanly, it lingers, interfering with healing, increasing stiffness, and sometimes contributing to what patients describe as a joint that never quite feels natural. Have you ever spoken to someone who says, "It's better, but it's not the same"? That's the biological reality behind the words. Now, let's step back and ask a different kind of question. What if the issue was never just the knee? What if it was systemic inflammation, muscle imbalance, metabolic dysfunction, or even chronic inactivity reshaping the joint over time? Because if that's true, and in many cases, it is, then replacing the joint without addressing the system is like changing the tires on a car with a misaligned frame. It may drive, but not optimally. So what are the alternatives? What is the longevity-aligned approach? First, we prioritize muscle as medicine. Strength training, even at advanced age, has been shown to reduce joint pain by improving stability and reducing load on the joint. Second, we address inflammation at the root. Nutrition, sleep, and metabolic health are not secondary, they are foundational. Diets rich in omega-3s, polyphenol, and anti-inflammatory compounds can meaningfully shift joint health over time. Third, we explore regenerative strategies. While still evolving, treatments like platelet-rich plasma, PRP, and targeted physical therapy protocols are showing promise in delaying or even avoiding surgical intervention. And finally, we ask a more honest question: is the goal to fix the knee or to restore the life around it? Because those are not always the same outcome. None of this is to say that knee replacement should never be done. In cases of severe degeneration, it can be life-changing. But it should be the last step, not the first. A decision made with full awareness of the biological cost and a clear strategy for recovery that goes beyond the operating room. Because in the science of longevity, we are not just replacing parts. We are preserving systems. And every decision we make either strengthens that system or quietly begins to erode it. There is another surgery that often arrives not with urgency, but with reassurance. It's quick. It's safe. You'll be in and out the same day. And in many ways, that's true. But what's rarely discussed is not the procedure itself, it's the biological ripple effect that can follow. I'm speaking about coronary stents, tiny mesh tubes inserted into arteries to keep them open, often after the detection of a blockage. Now, at first glance, the logic feels almost elegant. An artery is narrowed, blood flow is reduced, insert a stent, restore circulation. And in emergency situations such as an acute heart attack, this intervention is undeniably life-saving. But here's where we must slow down and look deeper. In stable heart disease, the story changes. A groundbreaking study known as the COURAGE trial, published in the New England Journal of Medicine, compared patients who received stents versus those who underwent intensive medical therapy, including lifestyle changes, medications, and risk factor management. The result: no significant difference in long-term survival. Let that settle for a moment. Because it challenges a deeply held assumption that opening an artery automatically extends life. What the study revealed is something more subtle, more profound. A stent treats the symptom of blockage, but not the biology of atherosclerosis. Because heart disease is not simply a plumbing issue. It is a systemic, inflammatory, metabolic condition driven by factors like insulin resistance, oxidative stress, and chronic immune activation. So when we place a stent without addressing those underlying drivers, we may improve blood flow locally, but the disease process continues globally. And sometimes, it accelerates. Now layer in aging biology. After stent placement, patients are typically prescribed dual antiplatelet therapy medications that reduce clotting risk but also increase bleeding risk. For seniors, this introduces a delicate balance. 1-4. One unnoticed injury. One internal bleed. The margin for error becomes thinner. And then there is the question of false reassurance. Have you noticed how often intervention creates a sense of resolution? I had the procedure. I'm fixed. But biologically, nothing could be further from the truth. Because the underlying terrain, the metabolic landscape that gave rise to the blockage, remains unchanged unless we actively transform it. So what does a longevity-aligned approach look like here? First, we shift from intervention first to foundation first thinking. We ask, what is driving the plaque formation in the first place? Is it blood sugar dysregulation? Chronic inflammation? Sedentary lifestyle? Nutritional imbalance? Second, we recognize the power of lifestyle as therapy. Studies from institutions like Cleveland Clinic and Harvard Medical School have shown that intensive lifestyle interventions, including plant-rich diets, regular physical activity, and stress reduction, can not only slow, but in some cases partially reverse arterial plaque. Not through force, but through biological recalibration. Third, we embrace movement as medicine. Blood flow is not just a function of open arteries, it is a function of demand. When we move, when we challenge the cardiovascular system, we stimulate the formation of new blood vessels, a process called angiogenesis. The body, in its intelligence, builds detours around blockages. But only if we give it the signal. And so the question becomes, are we outsourcing our healing to devices, or are we activating the innate systems designed to sustain us? Now, let me be clear. In acute, life-threatening scenarios, stents save lives. They are a triumph of modern medicine. But in stable conditions, they should not be the default. They should be one option among many considered carefully, contextually, and in alignment with the broader goal, not just to survive, but to thrive with a resilient cardiovascular system. If this is expanding your understanding of how deeply interconnected these decisions are, take a moment to like this video and subscribe. Because what we are building here is not just awareness, it's a new standard for how we approach health in the second half of life. Because the future of longevity will not belong to those who react fastest, but to those who understand their biology deeply enough to act wisely. There is a surgery that rarely feels optional. It enters the conversation with urgency, sometimes even fear. A word is spoken, cancer, and suddenly, the instinct is immediate: remove it. As quickly as possible. And in many cases, that instinct has saved lives. But today, we need to explore a more nuanced reality, one that has been quietly emerging from long-term data and epidemiological studies. I'm speaking about prostate surgery, specifically radical prostatectomy in older men. Let's begin with a question that may challenge conventional thinking. What if not all cancers need to be treated immediately? More specifically, what if some cancers grow so slowly that they are unlikely to impact lifespan, especially in later decades of life? This is not speculation. Large-scale studies, including those published in the New England Journal of Medicine, have shown that many prostate cancers are indolent, meaning they progress so slowly that a man is more likely to live with the cancer than die from it. In fact, autopsy studies have revealed that a significant percentage of men over 70 have microscopic prostate cancer that never caused symptoms during their lifetime. So why does surgery remain so common? Because once something is labeled cancer, our psychology shifts. We move from strategy to urgency. But biology asks us to slow down. Because prostate surgery, particularly in seniors, carries consequences that extend far beyond the removal of a gland. Let's talk about function. The prostate sits in close proximity to nerves that control urinary continence and sexual function. Even with advanced robotic techniques, these structures can be affected. The result: incontinence, erectile dysfunction, loss of autonomy in deeply personal ways. And these are not rare complications. They are, in many cases, expected trade-offs. Now pause and ask, if the cancer is unlikely to progress meaningfully, what are we truly gaining? This is where the concept of active surveillance becomes powerful. Rather than immediate surgery, patients are monitored through PSA levels, imaging, and periodic biopsies, allowing intervention only if the cancer shows signs of progression. This approach has been validated by research from institutions like Johns Hopkins University and Memorial Sloan Kettering Cancer Center, demonstrating that many men can safely delay or entirely avoid surgery without compromising survival. But the benefits go beyond avoiding complications. Because when we choose surveillance, we create space. Space to improve metabolic health. Space to reduce inflammation. Space to strengthen the immune system, which, let's not forget, plays a role in controlling tumor growth. Emerging research in immuno-oncology suggests that the body is not a passive host to cancer, but an active participant in its regulation. And lifestyle factors, sleep, nutrition, stress influence that regulation more than we once believed. So instead of asking, how fast can we remove this? We begin to ask, how can we create an internal environment where this cannot thrive? This is a fundamentally different orientation. One that shifts us from fear to partnership with our biology. Now, again, there are cases where surgery is necessary: aggressive tumors, high-risk profiles, rapid progression. But for many older men, the decision is not binary. It is a spectrum. And the most dangerous place to be on that spectrum is uninformed. Because once surgery is done, it cannot be undone. But a well-informed decision, one that considers not just survival, but quality of life, can preserve something far more valuable than the absence of disease. It can preserve dignity, autonomy, wholeness, and perhaps most importantly, the ability to live fully in the years that remain. Because longevity is not just about adding years to life. It is about ensuring those years still feel like your life. There is a surgery that often feels like a rescue mission. A moment where vision has faded, colors have dulled, and the world has slowly lost its sharpness. And then comes the promise: we can restore your sight. I'm speaking about cataract surgery, one of the most commonly performed procedures in the world. Now, unlike some of the procedures we've discussed, cataract surgery is often highly successful. For many, it truly does restore clarity and improve quality of life. So why include it in a conversation about caution? Because even beneficial interventions can become problematic when they are overused, mistimed, or disconnected from the broader biology of aging. Let me explain. A cataract is not a random failure of the eye. It is, in many ways, a reflection of cumulative oxidative stress damage caused by free radicals over time, affecting the proteins in the lens. So when we replace the lens surgically, we are correcting the result, but not necessarily addressing the process that created it. And that process doesn't stop at the eye. It is happening in the brain, in the blood vessels, in the mitochondria of every cell. So the deeper question becomes, is the cataract an isolated issue or a visible signal of systemic aging? Now, let's talk about timing. In earlier stages, cataracts may cause mild blurring or sensitivity to light but not significant impairment. Yet many patients are encouraged to proceed with surgery sooner rather than later. Why? Convenience, efficiency, standardization. But biology is not standardized. Because every surgery, even a minor one, introduces stress. There is inflammation. There is immune activation. There is exposure to medications that the aging body processes more slowly. And in some cases, there are complications that are rarely emphasized in pre-surgical conversations: dry eye syndrome, retinal detachment, increased intraocular pressure. Even subtle changes in vision such as difficulty with depth perception can affect balance, increasing the risk of falls in older adults. Now imagine this: a senior undergoes cataract surgery expecting clearer vision, but experiences slight visual distortion. That distortion affects balance. Balance affects mobility. Mobility affects independence. A small shift becomes a cascade. This is how interconnected the system truly is. So what is the longevity-aligned approach? First, we optimize the internal environment of the eye. Nutrients like lutein, zeaxanthin, and vitamin C have been shown in studies from organizations like National Eye Institute to support lens health and potentially slow cataract progression. Second, we protect against oxidative overload. This means managing blood sugar, reducing processed foods, and increasing antioxidant-rich nutrition because glycation and oxidative stress accelerate lens damage. Third, we consider functional thresholds. Instead of asking, is there a cataract? We ask, is vision impaired enough to meaningfully affect daily life? Because intervention should be driven by impact, not just presence. And finally, we prepare the system before surgery, if it becomes necessary. Strengthen the body. Stabilize inflammation. Support recovery capacity. Because a resilient system responds differently than a depleted one. Now, let me be clear. Cataract surgery, when truly needed, can be transformative. It can restore not just sight, but confidence, mobility, and engagement with the world. But when approached casually as routine, inevitable, or purely mechanical, we risk overlooking the deeper story the body is telling. And that story is always about more than one organ. It is about how the entire system is aging, adapting, and asking for support. So the next time you hear, it's a simple procedure, pause. And ask a more powerful question: is this the right time for my biology? Because in the science of longevity, timing is not just important. It is everything. There is a surgery that often begins with discomfort, but ends with something far more complex. A tightness in the chest. A shortness of breath. A scan that reveals multiple blockages. And then, a phrase that carries weight: we recommend bypass surgery. I'm speaking about coronary artery bypass grafting, often called CAG, procedure where blood vessels are routed around blocked arteries to restore circulation to the heart. Now, let's acknowledge something important. In certain high-risk cases, especially severe, multivessel disease, bypass surgery can extend life. It can relieve symptoms. It can restore blood flow where other interventions fall short. But in older adults, the equation becomes more delicate. Because this is not a localized procedure. It is a system-wide event. The body is placed under general anesthesia for hours. The chest is opened. Circulation is sometimes supported by a machine. This is not just surgery. It is a profound physiological stress test. And here is where aging biology changes the outcome. Let's begin with the brain. Studies have shown that a significant percentage of seniors undergoing bypass surgery experience postoperative cognitive decline, sometimes subtle, sometimes lasting. Researchers at institutions like Duke University have documented declines in memory, attention, and executive function months after the procedure. Why does this happen? Because the brain, like the heart, depends on stable blood flow and low inflammation. During surgery, microemboli, tiny particles, can enter circulation. Inflammation rises. Oxygen dynamics shift. And the aging brain, already more vulnerable, does not return to baseline. Now consider recovery. After bypass surgery, the body enters a prolonged healing phase. Energy demands are immense. The immune system is activated. Muscle mass declines due to immobilization. And here's the critical point: recovery is not guaranteed to restore prior function. For some, it does. But for others, especially those with limited physiological reserve, it becomes a turning point, a transition from independence to dependency. Have you ever seen someone who was never quite the same after a major surgery? This is often why. Now let's zoom out further. Because bypass surgery, like stents, addresses blood flow, but not necessarily the biology of arterial disease. Atherosclerosis is still driven by inflammation, lipid metabolism, insulin resistance, and lifestyle factors. So even after a successful bypass, the underlying process can continue in native arteries, in grafts, or elsewhere in the body. Which brings us to a deeper question: are we repairing the heart, or are we restoring cardiovascular health? Because those are not identical goals. So what are the alternatives, or perhaps more accurately, the complements? First, we explore comprehensive medical therapy. Medications, when used strategically, can stabilize plaque, reduce inflammation, and improve outcomes without the same level of systemic stress. Second, we invest in cardiac rehabilitation not as an afterthought, but as a primary intervention. Supervised exercise programs have been shown to improve functional capacity, reduce symptoms, and enhance quality of life, sometimes rivaling surgical outcomes in moderate cases. Third, we return again to lifestyle as a biological lever. Nutrition that reduces oxidative stress. Movement that stimulates vascular adaptation. Stress management that calms the autonomic nervous system. These are not soft interventions. They are molecular signals that reshape the internal environment. And finally, we assess something that is rarely quantified: physiological reserve. How much capacity does the body have to endure stress and recover from it? Because two individuals of the same age can have vastly different reserves. One may rebound. The other may not. And this is where personalized medicine becomes essential. Now, to be clear, bypass surgery is not something to fear. It is something to respect. To approach with full awareness of both its potential benefits and its systemic cost. Because in the pursuit of longevity, we are not just trying to keep the heart beating. We are trying to preserve the integrity of the entire organism: brain, body, and spirit. And sometimes, the most powerful intervention is not the most aggressive one, but the one that aligns most closely with the body's capacity to heal. So before agreeing to a procedure of this magnitude, pause. Ask deeper questions. Seek multiple perspectives. Evaluate not just the condition, but the context. Because longevity is not built on single elements, but on the accumulation of wise ones. There is one final surgery I want to explore, and in many ways, it is the most misunderstood. Not because it is rare, but because it is often framed as inevitable. A gradual loss of independence. Difficulty managing daily tasks. Moments of confusion, forgetfulness, disorientation. And then, a well-intentioned suggestion: perhaps surgery could help. I'm speaking about feeding tube placement, specifically in seniors with advanced dementia or severe cognitive decline.